welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Ben Thrower, who's here to answer as many of your questions as we can do in an hour. Let's see, I'd like to introduce him. Dr. Ben Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as the Medical Director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is Senior Medical Advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. When Dr. Thrower isn't dressing up as Jack Sparrow the pirate, he can be found playing with his grandson Sam and his granddaughter Opal. Now I'm delighted to introduce him.
Thank you very much.
Dr. Thrower, thank you so much for being with us. I'm going to turn it over to you and just explain to the guests before that how to have them submit their questions, okay? So everybody, if you have a question or comment, you can ask it by using the Q&A button in the app, which also allows you to send your question anonymously if you choose to. Or you can ask your question live by raising your hand. And to do that, you would click the raise hand button or press number 9, or rather *9, if you're on the phone. I'll call on you and then you'll be able to unmute to ask your question. So I'm going to turn it over to you. And we
Very good. Well, as always, thank you to everyone at the MS Focus for everything that you folks do. You guys are wonderful. I think you provide a great and much needed service to the MS community. It's been my pleasure to be the Senior Medical Advisor with you folks and look forward to many great years ahead. My hat's off to you guys for weathering the COVID pandemic. You did it like champs. So we'll get through as many questions as we can. Everything is fair game. There's nothing out of bounds. So yeah, if we want to start with maybe some that were emailed into you, we can go there.
Okay. So this is probably the first one that was sent to us a while ago. And let's see, they said, I've been reading a lot about the possibility of myelin repair in the future, specifically about clemistine. And forgive me, I can't pronounce it, ibidalist, slowing brain atrophy. Should we be getting our hopes up about the findings from these trials and any firm foundation for positive growth?
So I think the holy grail of multiple sclerosis is neural repair. We have now 22 FDA approved disease modifying therapies to stop progression. And in many people, we can do that, but we would like to be able to reverse disability also. And I do think there's reason to be hopeful. The clemistine was an interesting story. So it was part of a bigger project that was a joint effort between the National MS Society and University of California, San Francisco, where they were trying to identify molecules that are already FDA approved for some health condition and seeing if just by luck they might repair myelin. So the model for this is a test tube model. So you have a fake nerve fiber. It's called a micropillar. So you put this fake nerve fiber in a test tube, you put a solution in there that's conducive to cell growth, and you put a cell in there called an oligodendrocyte precursor cell that has the potential to become an oligodendrocyte, which makes myelin. But something has to turn that oligodendrocyte precursor cell on. So then you have thousands of these test tubes and you just start throwing random molecules in there. Again, things that are already FDA approved for something. So they got a hit in one of these test tubes on clemistine. Clemistine is the active ingredient in Tavist. It's an antihistamine medication. Why would clemistine, an allergy medication, promote myelin growth? We don't have a clue, but it did in the test tube. So then they took it to a human study of 50 individuals with permanent visual loss from optic neuritis, open label trial. So it's important to note that there's no placebo group. All of these folks knew they were getting active treatment. The researchers knew they were getting active treatment. All 50 of those individuals had some degree of visual recovery over 6 months. Very objective evidence of visual recovery. So there's now a much larger study going on through UC San Francisco. And I think it's just one of the many ways we're trying to look for different avenues to promote reversal of disability. The ibudilast is a medicine that's being looked at for secondary progressive MS. It's a medicine that's used in different forms of asthma. Again, kind of a repurposed drug. And there has been some early success with that drug. So I believe that is, if I'm not mistaken, is either a phase 2 or phase 3 study that's going on. So a lot of things out there. Here at Shepherd Center, we're doing a study with something called mesenchymal stem cells. It's a phase 1 study looking at reversing disability in people across all forms of MS, relapsing, remitting, primary progressive, and secondary progressive. So yeah, I think there is reason to be hopeful.
Interesting. She also had one other section of this question. This is from Tess. She said, I also read that with respect to ibudilast, it contains lipoic acid. I've been taking for years at Neuro's suggestion as a supplement and want to know if it does in fact mute nerve pain. Doesn't seem to help hers. So
yeah, so I think alpha lipoic acid is something where it's a supplement. You can get it over the counter. Is something where have been glimmers of hope for its use as a disease modifying therapy. I think of it more maybe as something for the long term sort of slowing of MS, maybe more so than reduction of symptoms. So I'm not sure that I would start it expecting it to improve something like nerve pain as much as I would maybe hoping that it might be something that might slow progression in the future. Again, there are ongoing studies. I don't think we have the final answer on alpha lipoic acid, but there are some glimmers of hope there.
thank you. This is a vague question coming in from Facebook. But MS medication, does it have to be taken for the rest of my life?
That's a great question. So when we think about disease modifying therapies, we usually do think of those as being long-term treatments. But there is this question, does it have to be forever long-term? So humans do go through a process called immune senescence. Our immune systems mellow out at some point. If you're looking at, say, a 90-year-old with a pneumonia, that calmer immune system may not be a good thing. So it's why maybe a 90-year-old with pneumonia might not do as well as, say, a 40-year-old with pneumonia would do. Their immune system has weakened too much. But if you have an autoimmune condition like MS, that calming of the immune system could, in theory, be a good thing. So maybe as we age, we don't need to be on a disease-modifying therapy forever. The trick is, we don't have an objective test to say when does the person hit that point. So if we had a blood test that says, okay, you're now age 68 and you don't need to be on your disease modifying therapy, that would be wonderful. We don't have that yet. So it's a little bit of an educated guess. It's a discussion that should occur between the person with MS and their healthcare team. A lot of different variables in there. How much of a hassle is your medicine? Is there a risk to your medicine? What is your risk tolerance for going off of the drug? So it is possible that people can come off of their treatments over time, but again, it's a discussion with a lot of nuances.
Thank you. Why is vitamin D essential when an MS patient is on an MS infusion drug?
So I don't think vitamin D is essential if you're on an MS infusion drug. I think vitamin D is essential for most people with MS, period. So 85% of people with MS are vitamin D deficient. Some of that's genetic, of the 200 plus genes that we know that code for a risk of MS. A big handful of those have to do with vitamin D metabolism. So a person with MS could do all the right things. They have a good diet, they have some sunlight exposure, and they still may have very low vitamin D levels. The reason we want to do something about that is vitamin D isn't just the bone density vitamin. The vitamin D plays a huge role in our immune system. And as vitamin D levels are low, the number of some inflammatory factors goes up. So the number of something called T regulatory cells is lower if you're vitamin D deficient. T regulatory cells are your friend in MS. You want more of those kind of mediating the immune system. So we want to check vitamin D levels in everyone with MS. We can't say that there's a perfect dose of vitamin D because it really depends upon where you're starting at And then we're going to sort of, recommend vitamin D dosing, but depending upon where your levels are at. And we're shooting for a 25 hydroxy vitamin D level on your blood testing of somewhere between 50 and 80 in general.
Yeah. Is high signal intensity on a cervical MRI without new or active lesions due to MS? And could it be due to other causes? Also, can MS cause myelom, myelom,
Malaysia.
thank you, of the cervical spine?
So when we say high intensity or high signal intensity, we mean a bright white area on MRI. And that's sort of the hallmark of when we talk about MS spots or MS lesions. They're usually bright on T2 or T2 flare images on MRI. But the person raises a good point. Not everything that's a bright spot is MS. There can be artifact. They're just, the person wiggled a little bit during their MRI, or the other things is some called signal averaging artifact. There are things other than MS that can cause bright white spots, more so in the brain than in the spine. So there are just numerous things on the brain MRI. So migraine headaches, hypertension, diabetes. Sometimes we don't know why people have little bright spots on their brain MRI. We used to use the term UBOs, unidentified bright objects, on brain MRI to say little spots that we didn't know why they were there. Cervical spine, thoracic spine is a little, the spots are more likely to mean something if they're there. But again, not everything is MS related. Myelomalacia is just the fancy way of saying you've got something wrong with your spinal cord. Myelo, spinal cord, malacia meaning bad. So it could be MS, it could be an old spinal cord injury, it could be a stroke in the spinal cord. If you've got bone spurs that have pushed into your spinal cord, you could get myelomalacia. So it's a broader term that could apply to MS, but it's not specific to it.
Thank you. Dee would like to know, how is cannabis for helping with sleeping, and how and where would she get it?
Big topic. So realize that every state has different laws on cannabis. When we say cannabis, we are referring to both what we think of as the marijuana plant and the hemp plant. So hemp and CBD products from hemp are legal in all 50 states. So you can buy legal hemp CBD with up to 0.3% THC in it anywhere in the United States. That can be helpful for sleep, and again, is easy to buy anywhere. When you get into more marijuana-based products where the THC is above 0.3, that's where you're going to have to know what your individual state laws are. It really does vary from full recreational legality to states that are much more restrictive. When we think about marijuana-based cannabinoids or CBD THC products, there's good data out there in MS saying they seem to help with spasms and spasticity. They seem to help with neuropathic pain, kind of burning, hypersensitivity, and they seem to help with overactive bladder. I think, although the studies are not quite as well developed, they can help with sleep as well. Although again, you may not need the THC component if you're just trying to sleep better. You might be able to get away with just using a CBD product if you're just trying to get better sleep.
Thank you. For those of us on a cell suppressing therapy, could Dr. Thrower explain a little about whether T cell function is enough protection from COVID? That's his first.
Another great question. So the honest answer is we don't know. So we know with the B cell therapies, so Ocrevus, Rituxan, Truxima, Kesimpta, that we're targeting the CD20 receptor on B cells. We sometimes can lower T cells with those drugs because there are some T cells that express CD20 as well. So that's something that we monitor with blood. We know when you do your COVID vaccine, your immune system does two things. It makes a T cell response and an antibody response. What we're finding is that about 80 to 90% of our B cell therapy patients are not making a great antibody response to COVID vaccination. The research says that 100% of people make a good T cell response. We don't have a great commercial blood test to measure that, but the research says everyone on a B cell therapy made a good T cell response. The question is that enough? And the answer is we don't really know. And in the real world, we have seen people on drugs like Ocrevus get COVID and have very minor symptoms. We've seen people on Ocrevus get COVID and get very sick with it, even when they're vaccinated. So, we do recommend that people get vaccinated. We like to check COVID antibodies to see if you got a response to your vaccine. And again, in about 80 to 90% of our patients, we're not seeing a great antibody response. And so we are offering the Evashield product, the COVID monoclonal antibody, to all of our B cell therapy patients. So the Evashield product is FDA authorized. You can read more about it on the National MS Society website. It's not a vaccine, it's passive antibodies. It's antibodies against two portions of the COVID spike protein. We're not asking your immune system to do anything. We're just passively giving you those antibodies. And it does look like it offers protection against everything we know that COVID has thrown at us. And it looks like it probably works against the BA2 variant that's kind of working around out there. So probably lasts for 6 to 8 months. No vaccine side effects with the COVID monoclonal antibodies, again, because we're not asking your immune system to do anything.
Imagine a patient has been on Ocrevus since December 2020 and stops getting Ocrevus infusions. What is the average length of time it takes for B cells to be restored?
Yeah. So when you get your dose of Ocrevus, it's knocking those B cells down, the ones that express that CD20 receptor, and the Ocrevus molecule itself is not sticking around for probably more than a couple of weeks. It's the effect in the immune system that lasts. It's going to last in most individuals at least 6 months, sometimes a little faster. We see people start repleting their B cells at 5 months. I have seen individuals go past a year after stopping Ocrevus. There really is a lot of individual variability, but they do start creeping back up probably at the 6-month mark. We have to be humble and realize too that what we're measuring in your blood when we look at the B cell repletion may not tell the whole story, because there are populations of B cells in your tissues, including your brain and spinal cord, that we're not measuring. And it may be that those cells are coming back faster than what we're measuring in the blood, but the blood is the best we can do. So the politically correct answer is 6 months, but I have seen people go longer than that.
Thank you. This person says, Katie, and she's obviously from in the UK. She said, hey Ben, I'm wondering why people in UK with MS that aren't on any immune suppressant don't get to have the 4th COVID jab. They don't realize how having COVID and the jabs affect us. When I had the first variant, I hadn't had a jab at that time, and it put me into a flare. So did the first jab. Now I know we won't be getting another dose, and I'm extremely worried as to cases in UK are the highest since it all started. Why do we have to suffer when normal people don't react like we do? Katie.
Yeah, that is a wonderful question. I wish I had a wonderful answer to go along with it. That involves public health policy decisions that are made. Different countries are making different risk benefit assessments, and I don't know why the UK has come to that conclusion. I will say, on a positive note, it does look like COVID is evolving and mutating in a direction that is maybe less severe. The Delta variant was horrific. Omicron, really contagious, but people tended to not get as sick with it. It looks like the BA2 that is out there is probably behaving similarly to the BA1, the original Omicron variant. So I think it's very possible to get sick from the BA2, but hopefully people aren't going to land in the hospital with it. I don't know what the situation is with therapeutics in the UK. So, we have the monoclonal antibodies like Evashield and Regeneron, and then we have the oral antiviral Paxlovid. Those therapies can be given to a person with MS just like anybody else. There's no contraindication. So I would say if someone out there with MS does get a significant case of COVID, just I would talk to your primary care doctor about the possibility of doing a therapeutic like Paxlovid or Evashield. They are very effective.
So Coy said, I understand that most MS patients have overactive immune systems, but if an MS patient is on a medication that makes them immunocompromised, should they start taking supplements to boost their immune system? And if so, which supplements would you suggest?
Yeah, so great points. So there's a mistaken concept sometimes that people with MS have by natural history have an underactive immune system, and that question asker rightly says your immune system is relatively overactive. So our hope is with MS disease modifying therapies is that we're balancing things, or maybe sort of just quieting down the part of the immune system that is relatively overactive. Clearly, some of our drugs, can be mildly immunosuppressant, sometimes even moderately immunosuppressant. So if our goal of therapy is to calm and quiet that immune system down, I would be cautious about taking supplements that might boost the immune system. That said, I think the data that supplements like echinacea, things like that, truly boost the immune system are not that strong. Vitamin C and zinc, I think you could use safely if you're worried about a viral infection. With vitamins C and zinc, I would probably think about using them sporadically at high risk times rather than all of the time. That's outside of vitamin C and zinc. I think the data that says that a lot of our supplements are clearly immune stimulant is not wonderful, but assuming they are, I would generally probably avoid those things, again, just for fear that maybe it is relatively contraindicated given what we're trying to do in MS.
Elizabeth would like to know, what level should vitamin D be maintained at?
Yeah, so generally when you draw 25 hydroxy vitamin D, which is the test you're going to do, we're shooting for that 50 to 80 range. When you get your vitamin D levels checked, sometimes you'll call into your doctor's office, you talk to the nurse, and so your levels are normal. Make sure they give you the number, because technically anything over 30 is normal. But we'd like you more normal than 31 or 32. So we don't want you just in the low normal range. We really want you up in the really good normal range, so in that 50 to 80 ballpark. Most of the studies that have looked for therapeutic benefit with vitamin D have shown that 50 seems to be the magic number. You want to be above that.
And Coy said one particular drug, Ocrevus, is known to improve a patient's rating on the EDSS scale.
Yeah.
Does this mean that they could possibly improve their walking with a cane to walking without a cane?
Yeah, so when we look at the really effective therapies, so things like natalizumab or Tysabri and Ocrevus, ocrelizumab, they're in the trials in relapsing remitting MS, there has been a small portion of people with MS that do get better. They improve on their EDSS. And I think that could be anything potentially. It could be vision, cognition, walking. It is it's not everybody. And so we don't want everyone on one of these more effective therapies to think if I don't get better, the drug's not working. I still think for most people, our goal with those therapies is to draw a line in the sand and say no more progression, no more MRI, new MRI lesions, no more relapses. Even if I don't see improvement, that could still be a success. The hard question is why are people getting better? And so we don't think these drugs are directly repairing anything in the central nervous system. It may be that they are so effective at stopping the inflammatory process that they are allowing natural repair mechanisms to take over. Whatever it is, we'll take it. When people get better, we're thrilled. But it is something that we'd like to understand a little bit more of.
Teresa's asking that she had the booster 4.5 months ago, and she's due to get the second booster. She'd like to know what your opinion is, whether she should get it.
Yeah, if you were asking me that question back in August through October of last year, I would have said absolutely, because we were dealing with a Delta surge at that point. I still think there's probably more benefit than risk. I think the risk is generally low. I don't, and this is, I'm just being completely honest, I don't feel as strongly about it right now. And part of the reason I don't feel as strongly about the fourth booster is because the virus has changed. You know, our vaccines were designed for the original COVID, and they happen to work really well for Delta as well. Well, the virus has kind of shifted now, and so the data from Omicron said if you were boosted, you had a lower risk of hospitalization and death. But Omicron was fairly mild for most people anyway, so I don't think it's a wrong thing to get boosted. I just don't feel as strongly about it. I know for like my wife and I as healthcare providers, you know, we may be mandated to do it. We healthcare providers were with the original vaccines and boosters, and I certainly wouldn't fight it if it was mandated. I don't know that I feel that strongly about us getting it, given what the virus is doing.
So Caroline said she's been taking Gilenya for 2.5 years, and she's 60 years old with no other comorbidities. She took the J&J vaccine last April, plus 2 Pfizer boosters. Her neurologist ordered blood work to check for antibodies in response to the shots. She tested positive for the IgRA test, indicating specific T-cell response to antigens of SARS-CoV-2, but have low and negative scores on the IgG and ACE blocker tests. So her neurologist suggested that she might consider waiting to take the Evashield, since she does have some T protection, and this medication is still fairly new and the data is still being collected on its performance and safety profile. However, he indicated that he is recommending Evashield for Gilenya patients who have other health issues, such as diabetes, high blood pressure. Her question is whether Evashield should be recommended for a patient with her profile. Should all patients on Gilenya get Evashield in addition to their vaccines and boosters?
Yeah, it's a curious thing. So if we look at our Gilenya patients, some of them, like she's saying, are not making great antibody response to vaccination. And I can't explain why this is, but I've not seen my Gilenya or the drugs that are in that class, the S1P receptor modulators. I've not seen them getting sick though with COVID like the B cell therapy patients do. And I can't explain why that would be. It may be that their T cell response is better. We don't have a way of quantitating that. You know, we can give you a numeric value with your IgG, with your antibody response. That's so I don't worry as much about the Gilenya patients when they're not having an antibody response, and that may be what she's picking up on through her neurologist, you know, unlike our Ocrevus patients. That said, do I think it's wrong to get Evashield? I would be completely comfortable going and giving someone like her Evashield right now, just because there's a lot that we don't know. And if someone is of a mind that they would rather be more protected, I think that's perfectly fine. You know, we use a lot of monoclonal antibodies, you know, Ocrevus and natalizumab and all these drugs. My suspicion is the long-term safety of Evashield, because it's a monoclonal antibody, it's going to be just fine. You know, it's not a forever thing. It's going to give you protection for a while, probably in the 6 to 8 month range. But yeah, I think for someone like her, I don't see a big downside to doing the Evashield.
Thank you. Linda's asking if Impera is given to help walking speed by helping nerve conduction, why isn't it prescribed for all MS patients? I started this year after increase in time for 25-foot walk.
Yeah, so people with MS have nerve fiber fatigue. So where the myelin is damaged, those are the weak links in the electrical conduction chain. And that manifests in a lot of different ways. It may be with poor walking, so that you walk 1 block, you're okay, 2 blocks, your foot's dragging, 3 blocks, 2 feet are dragging, and then maybe you poop out after that. It could manifest as you get overheated and your vision dims out. So exertional weakness and heat sensitivity are really the same underlying phenomenon. They're both nerve fiber fatigue, and that's where Impera is working. So we do generally want to at least put it on the table for anyone with that type of walking dysfunction. It was specifically studied for walking. Could it work for other things like maybe cognition? maybe, but it just wasn't studied for that. So unfortunately, insurance companies don't deal in shades of gray. The only thing they're going to approve it for is that walking speed. There is the old-fashioned version of Ampera, 4-aminopyridine. It is essentially the same molecule. It's a compounded mom and pop pharmacy drug, not FDA approved, but we can use that for anything. So that is available out there as well. So either form is acceptable. We probably should think about it more. I think one of the challenges we've had in the MS world is as we get more and more disease modifying therapies, and as the therapies get a little more complex, we're spending a lot of time having discussions about things we've talked about today, about vaccines and T cell responses and B cell responses. And at some point that seems to almost be at the expense of symptomatic management and quality of life, things like walking issues. So I think sometimes it just gets overlooked, that just we run out of time. But we know that about 40% of people who start Ampera will get a good response from it. 60% don't seem to get anything from it. That's another mystery. We would think everybody with MS would get a little benefit from it, maybe different degrees of benefit, but it really almost looks like it's an all or none phenomenon. The 40% love it and think it's the greatest thing ever, and 60% can't tell any difference at all.
Wow. We have a question about fatigue, and this person is saying that they have a teenager with MS since she's 14. Fatigue has always been her main complaint. I see adults with MS mention fatigue as a major concern, but it seems like it's downplayed by the daughter's neuro. She's active in sports and sleeps well. Tests to look for other causes have not revealed anything else as a cause. Various prescription meds for fatigue have not been effective. Any other recommendations to address fatigue?
Yeah, I mean, I think we're really still learning a lot about young people with multiple sclerosis. If you had asked 20 years ago, people would have said, no, a teenager can't have MS. And we know now that children under the age of 10 can have MS. And we need to think about the specialized care that they probably need. Fatigue is certainly can be seen in a teenager with multiple sclerosis. I think it is smart to rule out other things. My wife's a pediatrician, and she sees a lot of teenagers without MS coming in with fatigue, and sometimes it's because they're on their phone until 3 a.m, or gaming, or doing all kinds of other things that lead to poor sleep hygiene. But if you've covered all those bases and you come back to, okay, this looks like it's primary MS fatigue, I think going through all of the usual medications. We've got amantadine, the Nuvigil, Provigil, modafinil, or modafinil type drugs, true stimulant drugs. And then we want to make sure that we're not forgetting wellness kind of measures to help with energy levels. So it sounds like she's active in sports, and we want to encourage people to stay physically engaged and keep moving, because we know people with MS, teenager or older, decondition very quickly. And when they decondition, their energy levels drop.
Elizabeth would like to know if you would give Ampera to someone who had a febrile seizure at 18 months old.
Yeah, so one of the contraindications to Ampera is epilepsy. Most people, if it's a febrile seizure and you've had nothing since then, I'd be comfortable with that. If we wanted to be extra cautious, we could get another EEG just to make sure there's nothing that looks suspicious for underlying seizure activity. But febrile seizure is usually a one-time deal for most kids, and I don't consider that to be a higher risk for adult seizures on Ampera.
Now this is a long one, but I'm going to try to read it. My question has been answered by several neurologists here in Naples. I have had MRIs, including a lumbar puncture, and no lesions have been found. Lumbar puncture results showed normal results. I had almost all symptoms for at least 4 years or 5, which got progressively worse. As I started getting tested over time, for no reason that I can see, my health improved, and now I only have minor weakness on one side and slight vertigo and occasional optic neuritis flare-ups. There isn't much more to say about it other than there's been no indicators that I have MS or that there's anything wrong with me. Are there any cases where people have had MS, but for whatever reason, the spinal lumbar puncture and MRI showed up clear? Thank you.
So, MS can be tricky to diagnose. Our technology has gotten a lot better. So, a lot of facilities are now using 3T or 3 Tesla MRI scanners. That's twice the magnetic field of what we used to use. So early in MS, it is possible that the lesions could be really small. They can be tough to see. Early in MS, probably 50% of people do have normal spinal fluid. As time goes on, and so someone that's 4 years out, it becomes less and less likely that the MRI is going to stay normal. So I think it would be unlikely 4 years into symptoms that the MRIs, I wouldn't say it's impossible. We never go there, and nothing is 100% in medicine, but it would be extremely unlikely. Now, that said, in the MS world, so MS is a demyelinating condition. There are other demyelinating conditions that can be potentially transient. Usually those are going to cause abnormalities on MRI as well. So there are these cases like hers that are just humbling, that people seem to check all the boxes for symptomatically having MS, and we just can't find it, the underlying answer. I'm glad she's feeling better. I guess that's, and someone like her, I probably would get a periodic MRI, just to make sure nothing is evolving over time and that we're not getting fooled. I had a young man many years ago, a teenager, who clearly had lesions typical for MS, and in the midst of an ugly divorce and mom and dad arguing about who was going to have medical decision-making capability, we were trying to get this young man on treatment. This went on over about 2 years. His MRIs became completely normal and stayed normal, and I cannot explain why that happened. I was thrilled for him, but his MRIs completely normalized over time. And so, yeah, there are cases like that are just humbling and somewhat inexplicable.
Wow, that would be awesome, right?
Yep.
Incredible. So I'm going to try to unmute Karen because she has an additional question about the Evashield that she'd like to ask. Let's see if I can do this correctly. Hold on. Karen, are you there? Let's see. Aaron, are you able to figure out how to get her to be able to speak?
Yes.
Ah, good.
Unmute myself. Thank you.
There you go.
Given permission to unmute myself, so I did. Needed the permission. Thank you, doctor. I'm going to ask a specific question about Evashield, and I'm sure that there are others in this position. I got the original dosing of 150 whatever in February, and now I'm eligible for the second dose. I'm also, my neurologist does not do blood work to calibrate antibodies, since there's no clinical, best practices for that, but I am part of a study at the hospital. And after the Evashield, I went from 263 to 18,442 of the IgG against the spike protein. That was with what is the half dose. So I don't know. I mean, of course, I don't know what's the right number, and that was such a huge jump. Should I get the second dose?
Yeah, that's a tough call. So we use the Mayo Clinic assay for the COVID antibodies, and Mayo is very careful to say we don't know exactly what level of antibodies are protective with the IgG. We generally say above 500 we feel like is protective. 2,500 on it's interesting, in the Mayo Clinic assay they don't measure anything above 2,500, so you would be off their scale. mean, you should have pretty good protection at 18,000. Again, how long will it last? We don't really know the answer to that. But at face value, I would think you may not need that second dose. Is there any harm to getting it? Probably not. So yeah, it depends on how you feel about, getting the other dose. But I mean, I think biologically, it wouldn't appear that you necessarily need it.
Okay, I understand. Yeah, I'm a little scared to just, I take Kesimpta,
Yeah.
and I'm just a little nervous to put something in my system that isn't fully vetted. It hasn't even been used for a year yet. And does it actually help to promote T cells, or does it really just sit passively in your body until it's?
So we think that it's more passive. So it's binding, to that. So the Evashield, we're getting some feedback there. So it's binding to two parts of these. Evashield is two different COVID monoclonal antibodies binding to two different sections of the COVID spike protein. So it really is passive. That's why we don't see the vaccine side effects, the feeling crappy and having headaches and fever, because it really doesn't appear to need to activate anything like a vaccine would.
Have me stay there for an hour and take blood pressure every 15 minutes, which
and that's mainly due to there were some anaphylactic reactions that we're seeing in the clinical studies. So we do the same thing. We have people wait for about 45 minutes. If we're doing a lot of the Evashield on the same day that we're dosing Ocrevus, and so we will give the Evashield and then just wait 45 minutes or so before we start the Ocrevus infusion. But it's more for that short-term anaphylactic type reaction risk. Knock on wood, we've seen nothing with it. So we've administered probably 150 doses now of the Evashield.
And are you testing antibody levels to see if someone needs this additional dose?
So it's on a case-by-case basis. So it's, when people, it kind of depends on when people come in for appointments, but yes, we are offering that. Like you, I mean, our folks that got the one dose. So the original dose was, the 150 milligrams, and then they came out with a study and said that more is better. But we just saw people doing fine with the one dose. So now we are going ahead and just to be safe, we're going to get based upon the National Meth Society's recommendations, we're doing the double dose at with their initial dose, so that people don't have to come back in. But do people really need that? I don't know. I think they got a pretty good response with the single dose.
The first one, okay. I'll put it in that category of don't know, which is pretty much where everything else is. Right?
I think that's a pretty fair assessment. Yeah.
But your words are so meaningful in the world of don't know. So thank you.
Oh, thank you.
Oh, Aaron, could you kindly let David Bentley, who's from the Bahamas, could you take him off and let him speak also? I don't have the ability to do that. Okay, well, we're waiting for him.
Hello.
There's David.
Hey, how are you?
Good day, Dr. Thrower.
Thank you.
Yes. My name is David, and I am from the Bahamas. I have been living with MS now for 25 years, and spasms have started in my life from mid-December 2021. Because of MS focus, I am now on baclofen. I told my neurologist, and I'm on baclofen. And also because of MS focus, I learned about the apple cider vinegar and honey and the stretching and the exercise. I do that every day. And the magnesium oxide. My question to you, what else is there for spasms? Because I have those that occur on the right side of my body for about 10 seconds, and that's my right face side of my front up on my face. It happens on my hands, becomes stiff and crumbles up, and the feet start to get stiff. I'm just wondering, is there anything else that you have for spasm.
Absolutely. So when you think about managing your spasms and spasticity, again, you mentioned the stretching, and that's always your most important thing. So stretch, 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 yoga
Yeah.
programs, that's your base therapy. And then the baclofen is your next step up. With baclofen, generally what we will do is we will keep going up on the dose of baclofen until two things happens. Either you're satisfied with the degree of spasticity control, or you're starting to see unacceptable side effects. And the two big side effects with baclofen as you go up on the dose is either going to be drowsiness or weakness. We can give you enough baclofen to get rid of all your spasticity. The question is, can we do it without making you weak or sleepy? So through your local doctor, you can go up on the dose. The official highest dose is that regulatory agencies will talk about is 90 milligrams per day. In reality, there are a lot of people with MS that take more than that, and it's really based upon what you need and what you tolerate. One of the big rules with baclofen, though, is you're using it is never, never, never stop it abruptly. So if you're ever going to go off the drug, you want to wean off of it slowly. There is some seizure risk if you were to stop it all at once. There's another medicine called tizanidine. Tizanidine is also FDA approved for spasticity and spasms in MS. It has a very different mechanism of action from baclofen. It can be used along with baclofen. Also can be sedating, doesn't tend to cause underlying weakness. There's an old medication called dantrolene. Dantrolene, it's interesting, we don't use it a lot in MS. Here at our hospital across the hall, they mainly work with spinal cord injury. They use it in spinal cord injury all the time for managing spasms. It doesn't seem to work quite as well in MS as it does with spinal cord injury, but it does work. So that's another option. And then, the last thing that we would talk about would be cannabis. And so there is data out there, depending upon what the legalities are and your access are, to using cannabinoids, medical marijuana for managing spasticity. We're doing a study here in the States with something called Sativex. Sativex is a 1-to-1 mixture of CBD and THC in a little sublingual spray. It's made by a company in the UK called GW Pharmaceuticals. We know it works for spasms. It's been available in multiple countries for years now. Here in the States, we're just a little slower just due to legalities, but I suspect it will get FDA approval at some point here in the States.
Wow, thank you very much. I like the thing what you said about you can up the baclofen, and I'll try that one first. And because right now I up it to 20 milligrams 3 times a day. That's what my neurologist said. So now I'll try to get it up to 90 milligrams, because I sleep good with it. I sleep good with all my medication. I don't have no trouble with that. I'm a warrior, and come on, MS, let's go. Hit me with your best shot.
Keep that attitude. That's wonderful.
Yeah, man. Thank you.
All right. Take care.
Yeah, man.
Coy says, I've had 3 vaccines and a booster and will soon start Kesimpta. I'm still afraid of contracting COVID after becoming immunocompromised. My physicians have denied prescribing Evashield once I start the Kesimpta. Any recommendations on what more I could do to stay COVID-free other than the basic COVID safety suggestions, such as avoiding crowds, hand washing, etc.? I don't want to have to isolate myself from everyone forever.
So the good news is that situation where the vaccines and the booster have been given before starting Kesimpta is very different from getting the vaccines and booster after starting Kesimpta or Ocrevus. So the immunity that she's obtained, or he or she obtained from the prior vaccinations and booster, Kesimpta doesn't wipe that out. They may slowly go away just over time, just like anyone's immunity can after vaccines or booster, but Kesimpta doesn't take away the immunity. So the problem with getting vaccinated or boosted on Kesimpta or Ocrevus is it's more difficult to make the antibodies. So she made good antibodies, with the vaccination prior to that. The question, so you really probably don't need to do Evashield prophylactically before starting Kesimpta. At some point down the line, depending upon what's going on in the COVID world. So let's say COVID's still, lingering around into summertime. Well, at that point, it's probably going to be time to think about either a booster or Evashield. I think people on Kesimpta and Ocrevus get more benefit from Evashield than they do another booster, because I know the Evashield gives antibodies right now, whereas it's questionable as to whether another booster would. Now, the argument for doing a booster was Evashield's not giving you that T cell response that a booster would, but I think the data, to me, for someone on Kesimpta or Ocrevus, I would almost rather do Evashield versus more vaccines or boosters, because I know the person's getting antibodies.
Elizabeth, back to Evashield. After Evashield, I went from 0 to 150 IgG, but lab reports as high. Am I protected?
So that may be a different lab so if they're reporting that as high, so our Mayo Clinic assay would consider that positive. But again, the way we look at our Mayo Clinic assay is that I like to see them above 500. I think that's a different assay that they're looking at. So again, it's hard with these numbers because the labs are very reluctant to say, well, what's the right number? Because in all honesty, we don't really know what the right number is, but it sounds like that's a different assay. Evashield, I mean, I've not seen anybody not get a bunch of antibodies. So assuming she's within the 6-month window, which she's kind of got to be, since we only started using Evashield around December or so. I mean, I think she should be fine with where those numbers are.
Somebody's asking about their daughter, and this might very well be the same person that we spoke about. My daughter is on rituxin. Initially was told to get Evashield, but we couldn't find any doses available at that time. Now that the COVID numbers have reduced significantly, we've been weighing if she needs it now or should she wait until closer to fall when she'll live in a dorm at college. Thoughts on getting it now as it may be more readily available rather than in the fall if COVID numbers begin to raise again.
Yeah, I think if we had a perfect crystal ball and we kind of knew what was around the corner, it would certainly make these decisions a whole lot easier. I would, if that were my teenager, I would still keep trying to find it now, just because we don't have a perfect crystal ball. If I could find it now, I might go ahead and get it now. And then I would, if wherever I got it now, say, hey, will you have this again in August, September, when my daughter's about to go to school and live in a dorm? Can I come back and get it again then? Because I'll be 6 months out or so at that point. See if I can just redose. Again, there's a lot we don't know about long-term safety. Just knowing what we know about monoclonal antibodies, I'm pretty comfortable with Evashield, and I don't think we're going to see anything ugly with it in the long term. I would probably try to play it both ways if that were my teenager. Get it now and again come school year.
Thank you. I don't think I asked this question before. You can tell me if I did. Do you have any, Karen's asking this, do you have any feedback on the chionic neural sleeve that recently received FDA clearance?
I do not. I know just enough about it but I've not looked at the data on that. So we'll probably have to hold on that one. Maybe what we can do is if she wants to maybe email that question to you, Deb, I can do a little bit more research on that. I know just a little bit about it. I've really not looked at that, at what it took to get FDA authorization for that.
Okay. And Teresa's saying spasming, does gabapentin work?
Gabapentin can help with spasming. I wouldn't say it's the most effective thing for spasming. Again, we normally think of baclofen and tizanidine and dantrolene, but I have seen gabapentin take the edge off. Gabapentin, we usually think of more for the central neuropathic pain, kind of burning, hypersensitivity, more so than spasming.
And baclofen at only 10 milligrams per day. Please advise how to wean if needed. Can I just stop since it's just such a low dose?
Yeah, so at 10 milligrams a day, you're probably at the point where you could just stop that. So with once a day dosing, you don't have a steady state blood level, so you're getting a little bump in your blood level, and then it's pretty well gone. So at that kind of dosing, you could go ahead and discontinue that safely.
Good. Is dosing of Evashield and timing of rituxin administration critical for it to be effective, like other vaccines?
Yeah, the good question. And the answer is no. So because it's passive, we're not asking the immune system to do anything. You could do the Evashield and the rituxan. Really, the timing's pretty flexible. So again, the way we would do that is just for convenience. We would do your Evashield on the same day as your rituxan vaccine. Just do it right before your rituxan. Unlike a vaccine, we try to put some timing space between rituxan or Ocrevus and your vaccinations, because the rituxan is going to affect how well your body's able to make antibodies. That's not an issue with the Evashield because we're just passively giving them to you.
Okay. And Elizabeth would also like some information on the iconic neural sleeve. So what I would suggest to everybody that's interested in that, to take the email that reminded you of this program today and respond to that, asking for the information, and we'll make sure that Dr. Thrower sends it to us and we send it to you.
Yeah.
Okay,
Sounds like
that would be probably the best. Okay, let's see. Do we have any more questions? That was some good stuff. Great information.
Awesome. Those were great questions.
Yeah, let's see. Do we know when the forgive me for saying these things wrong, Sativex trial will be completed? It seems like they have been going on for a few years.
Yeah, it's going slower than we would like. And they are. So we're doing one phase 3 study right now. There's another one that needs to be done after that. The enrollment has been slower than we would like, and so it's a little frustrating. The trial itself is not that long. When you look at trials for antispasmodic drugs, usually you can do a 6-month to a year-long trial. They're much shorter than the 2 or 3 year studies that we do for disease-modifying therapies. But I think to GW Pharmaceutical and Greenwich is their American partner, they're being very methodical about it. They realize that we're going to be asking the FDA to approve a drug that is currently a Schedule 1 by the DEA. It's THC. And so I think they really want to make sure their ducks are in a row, that they've got all the data lined up. Again, we know it works. It's worked in multiple other countries around the world. I think it'll be interesting to see what the regulatory legal environment is like. By the time that second phase 3 study on Sativex is done, it is possible that marijuana is legalized nationally at that point from a recreational standpoint. And I think that makes the DEA hurdle a whole lot easier. It's one less thing to roadblock it.
Debbie wants to know, if you've received 600 milligrams of Evashield and on Ocrevus, do you need the vaccine?
I personally don't think you do. I think it's kind of you've gotten a boatload of antibodies from the Evashield. I don't think it's likely that you're going to make antibodies from the vaccine. The only, I think, theoretical reason you could say to do the vaccine was that you're probably getting a T cell response from that maybe you're not getting from the Evashield. But I just really do believe the Evashield is going to be protective by itself. So personally, I would not.
And Karen wants she has a question. Do you know when Evashield will be moved off the emergency use category and into full approval?
Yeah, that I don't know. I mean, you're looking at the way the FDA handled the vaccinations, that they don't seem to be in any giant rush to do it. So yeah, I really don't have a timeline on that.
But this was very nice. Joy said that FYI, she tested the NeuroSleeve. It worked for her, and she's on the early customer list. She's happy to chat with anybody that would like to know, and if it's helpful, she's happy to do that. So again, I'm going to ask that anybody that's interested in that would like from some information, just simply respond to that last email you got telling you reminding you today, and then we'll make sure that Joy gets that information. And Joy, if you would respond with your contact information, that would be even better. So that way we can get people. Thank you for offering. That was really nice.
Thank you.
Really nice. What is the antiviral SLOVID in parentheses SP that you mentioned earlier?
So that was Paxlovid. So that's a Pfizer product. So it's an oral antiviral. So it's not prophylaxis for COVID. It's used to treat COVID, if you get an infection. Think of it kind of like Tamiflu that's used for influenza. So if you get a significant case of COVID, your primary care doctor could prescribe the Paxlovid that would be an alternative to a monoclonal antibody to treat a COVID infection.
Let's see. I just wanted to say thank you. This is from Katie. Thank you for helping with my tinnitus question. Last time I've been to an audiologist and have been here having hearing aids and seeing a tinnitus therapist. So that's nice.
Very good. Good job.
Yeah. Let's see. Karen. Oh, I don't know. That one didn't make any sense. So I'm not going to say it. Let's see. Everybody's saying thank you. Thank you. Thank you. I know you can't see that because you don't have your glasses on.
That's right. Thank you, everybody.
Anyway, so that brings us to the end of our time. Let's see if we have any more questions coming in. Oh, people are saying such nice things about you.
Oh, thank you, everybody. I appreciate it. I love doing these.
Such nice things about you. You are so wonderful. We do have one last question. We'll take that, and then we'll by the way, people like your haircut too.
Oh, yep.
Oh, so Teresa said, I have relapse remitting MS. Why, when I get into a pool up to my knees, I feel the pain shooting in legs right away?
So people with MS have altered sensation. So that would be in the family what we would call a dysesthesia. So if you have a funny feeling, your legs are tingly, or you feel like there's water running and there's nothing there, that's a paresthesia or an extra feeling. If your paresthesia becomes uncomfortable, that's a dysesthesia. So people sometimes will say, I put my foot in cool water and it feels like I'm in molten lava. It's just abnormal crosstalk between naked nerve fibers. So you're firing off a nerve fiber that should say, okay, this is nice, cool pool water. This feels great. Instead, the nerve fiber misinterprets it and sends bad information to the brain, saying that it's something unpleasant.
Okay, thank you so much. So that brings us to the end of our time. If you missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access the recordings, or sign up for our newsletter to learn about upcoming events. Our next teleconference will be next Tuesday, April 12th at 4:00 p.m. Eastern Time. Our speaker will be Dr. John Schaefer, who will discuss Why Me? What we know about causes of MS, including the genetics. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Thrower, who's not only a wonderful doctor, but who's also a rock star at answering questions.
Oh, thank you.
Goodbye, everyone, and we hope you'll find the evaluation form that you'll be sent right afterwards when you leave the teleconference. Your answers will help us determine how best we can help the MS community with information that's meaningful to you. So it really benefits you to do that, rather than just say, I'll do it next time, but do it this time. Take that 2 seconds to do it, and we really appreciate that. So have a great rest of your day, everybody, and thank you once again, Dr. Thrower.
Thank you.
Bye-bye, everybody.